Is that recording? Okay. Recording has started. I think we can start with the session.
We are live, ma'am. We are live, ma'am.
Just a
Yes,
second.
ma'am, we sure.
Technical glitch. Do I have my slides visible now?
Not, no. I think it's Dr. Bhatia's slides that we can see.
Or maybe I can just start with the introduction and let's his slides be there. That's
Sure,
so.
sure. Okay.
Should I start?
Yes, ma'am, we are live.
All right. Hello, everyone. Good evening. We really welcome you all to this webinar series that Fortis Hospital is organizing. And we're really delighted to invite all the pediatricians, all the pediatric oncologists, all the pediatric neuroradiologists to this session 2 of our webinar series, where we have a very special guest. So, whenever we are dealing with pediatric brain tumors, we have a very basic aspect of where to start, how to start, and let's image the stuff, let's image the problem, and then get to further come with the problem. The magnitude of the problem, the site of the problem, how big the problem is, and where to hit the biopsy so that where we can know what we are dealing with, we can know whether we need to go for a biopsy, we need to go for a resection, where we need to hit the neurosurgeon's help. And it also gives us the magnitude of the problem so that we know that whether the magic of the treatment has worked or not, whether it has undergone an unfortunate progression, and how is the tumor responding to things. So today I welcome Dr. Ashim Bhatia. It is a great privilege to have him. He's a pediatric neuroradiologist in the Division of Neurology, Children's Hospital, Philadelphia. He's an assistant professor of radiology, Perelman School of Medicine in University of Pennsylvania. Very welcome to you, Dr. Ashim, and I really hope we learn a lot from you through this session.
Thank you, Dr. Bayana. Yeah, appreciate the invitation to present here. Really fortunate to present to Fortis Hospital and all the people online as well. Sorry, I got a little cold. I'll try to get through it with a lot of sips of coffee on the side. But I've done a lot of work with brain tumor imaging and trying to standardize the imaging approach. So I'm going to go over how that has an impact in clinical practice and some of the reasons we do that. So I got to work with Dr. Zoltan Pate, who was the chair at St. Jude. He unfortunately passed away. So a lot of the work first started with him as far as standardizing imaging protocols. So this is acknowledgement to him. The outline will be a standardized imaging approach. We'll talk about RAPNO criteria and COG criteria as well, and some of the imaging approaches with that. So standardizing imaging, if not upheld, can cause some challenges. Some of them are inaccurate staging. You might have to have repeat imaging, sedation. So that's extra burden on the patient, family, on the institution. And you get poor outcomes if you're not accurately staging. One of the other challenges is between institutions trying to compare between them. That can be a challenge if your imaging protocols are not the same. This was a COG trial. I'm a COG central reviewer, medulloblastoma trial. And what they saw in this trial was that the imaging protocols were inadequate. So we have certain requirements, and the slice thickness, certain sequences were not done. So that required 80% of them. Let's put this 80% of them to have repeat studies. That's a large percentage. And some of them were inaccurately staged, partially related to imaging protocols, and that resulted in inaccurate staging, and that can obviously result in poor outcomes if not adequately staged or demarcated as the correct tumor location with metastatic disease. So those things all have to be factored in. So here's an example. 4-year-old presents with left-sided weakness 3 weeks after radiation. So here's the tumor, biothalamic. And this was tumor here too. 3 weeks after radiation, the signal increased. So all this bright signal got worse, but we didn't know if it's radiation or is this post-treatment change. So that's one of the challenges in clinical practice. You want to make sure you get accurate staging. And after months after radiation, it was clear this was tumor progression. So we want to know earlier to get better outcomes in patients. But I'll go over the best way to approach it with the current clinical practice. Here are the RAPNO criteria, response assessment in pediatric neuro-oncology. They have multiple papers. I was an author on the ependymoma paper, so you can see right there. And we go through and try to develop the right imaging protocol for these specific tumors. And I published a summary paper here. It's a good one if you want to get an idea of what all 6 papers show. And here's a summary of the sequences and the different tumors. So you can see medulloblastoma up to ependymoma. There's a T1 sequence, and each one where it's highlighted is the sequence that is essential for each tumor type. So really, the only one that didn't have a T1 2D sequence was a craniopharyngioma. We can see 3D T1. There's a T2 sequence, 2D, which all of them require. T2 flare pre-contrast. So a few of them. This is a T1 2D with contrast. This is diffusion-weighted imaging. Pretty standard. This is a very important sequence here, diffusion-weighted imaging. And I'll show a little bit as we go along. T2 flare. And this is a sequence, again, I was an author on the ependymoma paper, and the one sequence we felt was very essential was called a balanced steady state free precession sequence, which on Siemens and Philips have different names. So it could be CIS or other names like on each vendor. So if you look at these sequences, we try to develop which ones are the most important, but you're not going to have a protocol for each tumor. And when a patient presents, you don't know what tumor it is sometimes. You really don't know until biopsy. So as you go through these sequences, you kind of look at a protocol like this, where you get diffusion-weighted imaging, you get your axial T2, flare, SWI, post-contrast imaging right here. So that's about close to an hour. This is perfusion-weighted imaging. And I'll show this sequence was that balanced steady state free precession sequence. And when you add it to a post-contrast T1, you're much more likely to pick up metastatic nodules. You can see here, this sequence was able to pick up 36 versus the post-contrast missed some of those nodules. And this is what the sequence looks like. So here's your post-contrast T1 with the balanced steady state free precession. You can pick up nodules. And we do this in the spine at my institution as well. So in the spine, you can see here, these nodules are much more likely to be picked up. So metastatic nodules are picked up quicker. And again, these are the names of it on different vendors. Here's one example where an ependymoma after treatment, this is at baseline. After treatment, you don't see anything on the post-contrast T1, but there was still some residual disease on this sequence. And you can see it right there. So the advantage of doing the sequence through the area of interest in ependymoma patient follow-ups is important. Here you go again. Nodules in the spine. See these right here? But you don't really see it on the post-contrast T1. So that's the spot about right there. Really hard to demarcate it, but we've seen a lot of advantages with this sequence. And post-contrast flare, this is a very sensitive and metastatic disease. Here's some examples where if you do a post-contrast flare, you'll see more than just a post-contrast T1. Again, post-contrast flare versus post-contrast T1. And studies have shown if you add the post-contrast flare, you're going to pick up more metastatic lesions. So 242 versus 185. You'll be able to see more disease with this type of sequence. And here's an example that I have. Post-contrast T1 versus post-contrast flare. So all this bright signal is metastatic disease. And when you go back to the T1, it's really hard to see it. You see some of it right here, right there, but you don't see all of this. Again, the post-contrast flare is much more sensitive at picking up early metastatic disease and the extent of metastatic disease. This is the same patient lower down where it was pretty extensive as well through the sylvian fissures, through the sulci and frontal lobes. So we had multiple experts get together, mostly neuroradiologists, to develop one protocol for all the brain tumors. This was the COG SPR white paper. So I was a senior author, got to work with everyone. We looked at rhabdo, literature, expert opinions. And what we want to develop is what we call a standard of care imaging. What we did was we rated the sequences we thought were most important, 1 being very important, 4 not so much. We also looked at the literature to support it. If there was a lot of literature to support it, it was a code A versus not enough literature, more work was needed, code D. So A, B, C, D, and 1 to 4. I'll show you what we developed. This is a summary of the important essential sequences. You have a 3D T1. So you look at very strong score. I'll just highlight that. You can see all these are essential sequences, what we call them, or standard of care imaging, and a lot of support by the literature A and B. So it's 3D T1, diffusion weighted imaging, SWI to look for a hemorrhage or calcifications, T2, post-contrast T1, and a post-contrast flare. So those are the really 7 important sequences with slice thickness and other details here. This is more your optional sequences. Some really important, but not enough to make essential. So here's some examples. We talked about that balanced steady state free precession. That was what I just showed in the spine and that ependymoma example. Highly recommended, strong recommendation, but not enough support for it to make it essential. And also it's a long sequence. So time on a scanner is obviously important. What about MR spectroscopy? Also a strong recommendation, but still not enough to make it an essential sequence. There's perfusion weighted imaging and diffusion tensor imaging. So let's take a look at what about just a head CT? Well, it's strongly recommended when you're first uh, an on first presentation of a patient that's concerned for a mass. This is a good first imaging approach where you can screen for hydrocephalus, hemorrhage, calcifications within the tumor. This all has an advantage. It's quicker, more readily available, and you don't necessarily need a post contrast. It's going to be a non contrast CT. And there's other immediate post operative evaluation for complications. This is also an advantage of CT. Here's an example. Here's a mass in the right posterior fossa, calcifications, cystic components, solid components. And when I look at tumor, this is a DWI sequence, post-contrast T1. Some of these details you won't see easily on CT, such as the calcifications, and a mass is more of a high-grade tumor. But the point here is CT has a role, and you can also see the hydrocephalus, the right temporal horn being enlarged. On MRI, again, highly recommended. This is essential, obviously, for tumor workup. 3 Tesla's preferred. You can do it at 1.5, but 3T has its advantages. And we'll go more into MRI again, but just to make a point, when you're considering MRI, the challenge is to do it with sedation or non-sedate. So with sedation, we try to do it in patients younger than 6 years of age, and 0 to 3 months of age. You can try to non-sedate, feed, and swaddle. That's an option. And we also have other ways to get patients to stay still on the MR scanner. Contrast is essential for characterizing the mass, and really also very important for metastatic disease. That's one advantage of contrast. There's very few sequences that can really replace a post-contrast sequence. So that's important for tumor workup. And you prefer macrocyclic contrast agents because of the concern for gadolinium deposition in the brain with the linear contrast agent. Now, diffusion tensor imaging is a diffusion weighted imaging approach. And you can see here, still pretty good score, the 1.5 that I mentioned, and good support from the literature. This is helpful for pre-surgical navigation and also helpful for neurologists to look at certain types of tumors. We use the diffusion weighted imaging. Here's the patient with a stroke where you get restricted diffusion or reduced diffusion. And we look at it in tumors too. The tumor within the humerus has restricted diffusion. Tumors in the posterior fossa can have restricted diffusion like this one. But all we're looking at with diffusion tensor imaging is an advanced form of diffusion weighted imaging where you can infer tissue microstructure and the connectivity within the brain. Now here's an example. We get a bubbly lesion in the left parietal lobe. The tractography shows the white matter tracts being displaced around the tumor. So if you resect this tumor, there's going to be less complications versus a tumor like this, which is more like a infiltrating tumor where the white matter tracts are going through the tumor. Or in this case, you can look at it this way, the tumor going through the white matter tracts. So if you're going to resect this, you can have much more complications in this case versus this tumor. So that's one advantage of diffusion tensor imaging. Puncture MRI, you can do a whole presentation on it. I won't go into it, but it is a preoperative tool you can use for neurosurgeons to map out language centers and potential complications. MR perfusion imaging, I won't spend too much time on it, but there's advanced forms of diffusion with imaging called dynamic susceptibility contrast, dynamic contrast enhancement. So they have good scores. The They have good grading, as decent grading actually. The challenge is not enough literature to support it. The scores are, I think, with more literature, this score would go up, potentially have more use in the future. And this is a contrast type of perfusion, where when you inject, you can measure different variables within the brain tumor microenvironment. So leakage or contrast. But a lot of places, I would say, don't do it. We don't do it currently. We're looking into adding this to our imaging protocol. And here's an example of that post-contrast imaging I just mentioned, that TCE, DSC. You see it right here. So that's about almost 9 to 10 minutes of imaging just from those two sequences. Where if you look at the rest of it, like 1 minute, 7 minutes, another 5 minutes. So it's a very time-consuming protocol, and you got to have an advantage of doing it. So that's that's where we're at now, trying to study the advantage of this, where you could potentially differentiate low-grade from high-grade tumors with this approach. And these are some of the variables that they looked at. No need to go into details of that. But when you do add perfusion modalities to sequences like MR spectroscopy, you can see improved diagnostic accuracy of determining recurrent tumor. So it has advantages in those cases and has a lot of potential, I think. Arterial spin labeling is a non-contrast form of perfusion. Again, a pretty good score, but not really great like the other sequences, and still need a little more literature to support it. This was one study that looked at it in grading of tumors in children. There have been a lot of variability in the data. We published recently ASL and hemangioblastomas, what we call the light bulb sign. So you can see here, a tumor like this is actually a medulloblastoma that had partial perfusion. This is high perfusion within the tumor. So it was only really part of the tumor. Hemangioblastomas, other than the cystic portion, have very bright perfusion, high perfusion throughout the tumor. So this was what we call the light bulb sign, an imaging marker for this type of tumor to help differentiate from other tumors. And you could use it in recurrent tumor potentially. Again, more work is needed. For MR spectroscopy, this is my daughter telling me, make sure you use MR spectroscopy. So she is a supporter of this as well. But you can see the score here is pretty good. There's a lot of variability in the community on how to use it. I think if you do it consistently, it has the advantages of differentiate types of tumors, potentially tumor from other mimics, and the single voxel, multivoxel approaches. I won't go into a lot of detail of the technique, but I do think there is a role for it in the clinical setting. And some of the emerging techniques that we currently have are, well, AI, radiomics. There's a lot of literature out there on that. My lab focuses on sodium MRI and CEST imaging. Ferumoxytol has some approaches as well, some advantages. That's in the research setting. So all this is research for the most part. And this is trying to find its way in. And again, PET for the most part, still primarily research, but these are tools you might see in the future in the clinical setting. And in summary, an optimized approach, standardized approach, is to improve the accuracy of staging and response assessment in patients with tumors. And if you implement these clinical practices into your clinical practices, imaging protocols, you can do better studies as far as multi-center clinical trials, easier to compare, and better outcomes for patients. So that was an overview of imaging approaches. Happy to answer questions. These are some pictures. Actually, when I got to meet Dr. Gupta at Fortis Hospital a few years ago, it was a true pleasure. Here I presented at PGI at Chandigarh a few years ago as well. And then a few months ago, was in Goa, India, for a radiology meeting, which was a fantastic time. It's always a pleasure to be able to speak to my friends back in India. So hopefully we can do it in person one day. We get to meet in person. Sorry about my voice. Hopefully it was easy to understand. But again, thank you again for the opportunity to present.
Thank you so much, Dr. Ashim. And I really can assure you that the voice of yours did not hinder the amazingness of this lecture, even a cent percent. This is really amazing, and this is really up to the mark because we always are confused that what to order, which sequence to see. We are always running to the radiologist, which sequence to order, which sequence should we see, spinal meds we have to see, which sequence should we bother, we should get a flare done or not, we should get an MR spectro done or not. We're always confused about that thing, especially during initial evaluation, because that marks the basis of how the tumor is going to respond, how we'll assess our responses. So thank you so much for this very amazing lecture. It was really nice to have you. I have questions flooding in, so I'll if
Thank
you're,
you.
I don't want to bother you in between your caffeine shot.
Oh, no, you're fine.
So the questions pouring in, I'll just pass them forward. Thank you, Dr. Ashim. The first investigation of choice in any suspected brain tumor, will you order a CE-MRI or something else?
Well, I think it depends. If the patient's clinically, if there's concern for increased intracranial pressures, we usually get a CT first to look um, for any hydrocephalus, large mass, rule out other potential intracranial pathology. That's just a non-contrast CT. We also have a screening MRI I didn't show that one, but it's about 10 minutes of imaging on MRI just to look for a large mass. So that's sagittal T1, coronal T2, axial DWI, axial flare, and axial gradient. And they're very, so I mentioned the slice thickness. I showed some of the essential requirements for each sequence. That screening MRI does not meet those requirements. It's thicker, larger gap to make it faster. So it's a screening study for a large intracranial pathology. But in general, once you get past that stage, then yes, a contrast enhanced MRI is our first important, really first imaging approach to really making sure you're not missing a tumor.
That's the usual practice we actually follow. But having said that, in children, the sedation time and everything logistics we have to sort. So that always like makes it problematic for us. The next question, what are some negatives of not following the standard care of imaging? And what can be done to improve imaging to fit the criteria better?
Yeah, good point. That's and I kind of pointed to it at the beginning was if you don't follow those sequences, you might miss metastatic lesions, you might miss residual disease, you might miss recurrent disease, and that can present with poor outcomes for the patients. So that's one important thing. And also comparing, we get patients that jump from different institutions, one to another. And if trying to compare different time points can be very difficult with that as well. If you don't have similar imaging approaches, we have that a lot at CHOP where patient comes from somewhere else, the imaging protocol is not adequate. And then for clinical trials, if you don't meet the requirements now, you're not actually allowed to enter, not all of them, but for some clinical trials, you must meet the standard of care imaging to get into the trial. And I'm a central reviewer for the COG. So a lot of patients, we screen them for making sure that they have the right imaging before they enter the trial as well.
So that's in fact a very important point, the universality of the whatever the imaging we are following. Because this is a very common problem we face, that we have some sequences, some 1.5 Tesla MRI, just few sequences. Many a time patients don't even carry the CDs, and even we go to the radiologist and we understand they're pissed, but we are like, just tell us it's a response or not a response, just tell us what is the diagnosis. So that does is a problem. So having a universal protocol throughout, though a very far-fetched aim, but definitely is the aim, so that at least we provide the kids with brain tumor who even switch centers with a better care. So that's a very
Yeah,
important
and
point to highlight. Yes.
yeah, and that protocol I showed with that COG white paper overall protocol, the other reason we picked it is almost any MR scanner can perform those sequences. They're not advanced. So we factored in variability in institutions, resources, time, try to make it essential, which that protocol should be somewhere in the like 40-minute range, which is um, 30 to 45 minutes, depending on how you use your scanner. Like a 3T is faster than a 1.5T with similar imaging resolution and um, uh, quality of the sequences. So that's there's some variability in timing, but for the most part, almost any MR scanner can do it. And I know I've been to other places. I know the resources, trying to get access to MRI can be tough. So that's why I mentioned CT is a good first step in those cases.
Definitely, CT does play an important role. Next question, boss, frequently do you recommend MRI in a follow-up case of brain tumor, and for how long?
Yeah, again, that I used my neuro-oncology colleagues to help direct timing of it, but I'll kind of push them to go sooner in some cases where if I see something concerning, it's always MRI. So I always say contrast hence MRI. Timing wise, it depends on the case. So if there's something I see concerning and they're supposed to come back in a year, I'll say, well, get that sooner, maybe 3 months, 6 months, depending on the tumor type. Like a high grade tumor, we're more concerned. All right, do it sooner. A low grade tumor takes longer to grow. The changes you're not going to see much of a change in 3 months. So you might say, all right, 6 months to a year is fine. But it depends on each case. And neuro-oncology colleagues like you and
अच्छा उसको कनेक्ट करना पड़ेगा
clinicians are much more skilled and experts in that field of timing as well.
So talking about low-grade glioma, that is always a problem for us. Whenever we are assessing low-grade glioma as an upfront case or as a response, we're always stuck whether it is a response or not a response. So we're always, by conventional learning, we feel like a static response to a low-grade glioma, like not increasing in size, a cystic component increasing. They're all counted as response. But having
Yeah.
said that, for somebody who's dealing with the family, explaining that to the families, and convincing even ourselves on progressive scans that no, this is static, no, this is static, this will be okay, this won't grow one day, and then suddenly it grows after 2 years. So that is always a problem. So what is your take on that, sir?
Yeah, I think the the key with these low-grade tumors is you need to go back at least 2 years, 3 years, and compare to that time point. Because what happens is we'll look at it every, suppose, 6 months. And then between that 6 month interval, you don't see that difference in size. It might be a millimeter, and you say no significant change. But if you go back 2, 3 years, that 1 millimeter is now changed by 5 millimeters. So that's the key with the low grades is that because they grow so slow, you can't just look at the last MRI. You got to look back years, and that'll help give an overall picture to the neuro-oncologist and the patients and families of what's really going on with this tumor. And look for, I mean, it's also important to look for secondary findings, look for the mass effect, look for potential hydrocephalus developing, other complications from the slow growth over time.
Definitely. So those subtle signs have to be picked more than actually the response of the size criterias in low grades.
Yeah.
Next question, sir, for you. Any escape from the long problem of the long sedation time and long procedural sedation hours that the MRI brain takes in pediatric patients?
Yeah, it's good question. I mean, there's ways we have like patient child life services that helps with the patients to get them comfortable with the MR scanner. That's one way to get them to stay on the scanner longer without sedation. Uh, the other thing is working with the MR physicist to make sure your sequences are in the right order. So, for example, make sure you get the essential sequences first. You could do spectroscopy at the end. Uh, Make sure your sequences are as fast as possible with the right quality. That way you can, again, potentially avoid sedation. But in general, if a patient requires sedation, there's no way to avoid it, unfortunately, at the current time. I would say as patients, the neuro-oncology patients, they kind of get used to the MRI. So as they get a little older, they're more likely to stay still. So another way to avoid sedation. But yeah, I think it's a team effort. So unfortunately, some patients require it, and there's a ways to avoid it and be more efficient with the MR scanner.
Yes, that is always a problem. But yes, as you said, kids do get accustomed. They do know that it's 3 months and I'm here in the hospital for a MR scan. So
Yes, exactly.
maybe a magic or blessing in disguise for us, but we always try to escape that problem.
Yeah.
Just the last question for you, sir. What are the next steps in RAPNO criteria?
Yeah, that's a good point. So RAPNO was developed to assess treatment response of these different types of tumors, and we're in the current stage of validating those sequences. So those were those were sequences that were suggested as the best. So now we're going back to different types of trials and studies, more retrospective, but also prospective, to see if these sequences do adequately assess response. And that's the current state that we're in. We'll be probably looking at, and I'm actually involved in a few studies right now that are looking at RAPTOS criteria in different types of tumors, medulloblastoma, and we're seeing maybe another sequence is needed, maybe some are not. So there'll be potentially modifications to RAPTO in the future.
Um, I think that's it with the question session, sir. Thank you so much once again for those amazing sessions and simplifying that puzzle of T1, T2, diffusion spectroscopy always for us. I have Dr. Verma sir with me. Dr. Verma and Dr. Gupta are there with us in Department of Radiology at Fortis, and they both are our to-go person to always, we are always bothering them, and they always see us running around with CTs or MRIs, and they always fear that we'll be carrying some weird quality scan and hitting them with questions. um,
Yeah, it seems like that's a universal challenge, right? Everywhere. But it's important to work. I mean, I always enjoy working with the neuro-oncology team members to get history, look at the imaging together, and determine the best next approach for these patients. So it's always a pleasure to learn from all of you as well.
Thank you so much, sir. Dr. Verma, please your take for this amazing session that we just had.
Yeah. First of all, thank you very much for giving a very insightful uh, knowledge of the pediatric tumors, especially from the the questions which were put by Dr. Swati, that what is the requirement by the pediatric oncologists, etc. But I think in our center we are probably using best of the sequences and best of the scanners, and we are keeping no stone unturned to help in making the diagnosis of the tumors. And let's hope that we keep on doing that. Yeah, that's true. So we have my boss, Dr. R.K. Gupta. He's a pioneer in spectroscopy. It's a random name in spectroscopy and brain tumors. We have our own software actually we are using for brain perfusion.
Oh yeah, nice.
Yeah. So it is T1 based. It's a dynamic contrast enhanced, T1 based, not on susceptibility based. DSC.
Okay.
It's not. We are not using it on a DSC basis, but
Gotcha.
we are using it as a T1 post contrast enhanced dynamic study. So it's working fine for us. I mean, we have been. I'm not using the other systems now because for the last 10, 20 years. So
that's good. I have to find out more info from you on that, because I started doing it in my prior institution, the DCE, DSC, and it's post-processing that's been the inconsistent between different institutions.
Yes, that's true. And in the last 10,
more...
12 years of our association, quite a number of improvements have been done, which I have seen myself over a period of time, like the post-processing thing. So the sir is constantly in touch with the medical physicist, IIT Delhi, and engineering people and research people to upgrade the software further. And it's very nice for me, actually. I really like the software.
Oh, that's great. Yeah, I think it has a lot of promise. And have you used it more in recurrent tumor? Or
yeah, recurrent tumors also, because in those cases perfusion is actually more useful.
Yeah.
Rather than any other system like treatment induced radiation necrosis and everything. Though spectroscopy we are doing along with perfusion studies and making the diagnosis.
Yeah, I agree. I think that currently that's the best clinical approach.
Yeah.
There just was not enough literature for us to support it as like an essential sequence, but I think you're right. That's the best approach currently to differentiating those treatment responses.
Yes, that's right, sir.
Very nice.
Thank you very much for your talk. I joined late. Initial part I missed but when I can understand the jinx of it, whatever you were talking.
Oh, fantastic. Yeah. If there's any other questions later, let me know. And I put my email at the end of the presentation, or I can send it. I think Dr. Bayana has that as well.
Yeah.
I'll definitely share that, sir. Thank you so much. It's really my pleasure to host you. Thank you so much.
Thank you very much.
Thank you again. Appreciate it.
Good day, sir. Good day.
Good day.
You too. Bye-bye.